Dr. Sameh Emil. He will talk about the STEP trial. Dr. Sameh.
مورنينج وثانك يو فيري ماتش. انا بشكر جمعيه الضغط والدكتور محسن ابراهيم ومجلس الاداره، وبشكر رؤساء المؤتمر الاستاذ الدكتور فتحي مقلدي والاستاذه الدكتوره جميله نصر على دعوتي للمشاركه في السيشن ديت. ثانك يو مستر تشيرمان. قبل ما ابتدي بس انا يعني I have to admit ان انا استمتعت بمحاضره الاستاذ الدكتور حسين رزق لانها كانت رائعه فعلا. نشكر حضرتك جدا. In the same يعني session بتاع what is new in hypertension trials, as Professor Karim demonstrated the SPRINT trial, we have another trial in the same way, which is the STEP trial. The STEP trial was published in the New England Journal of Medicine, September 2021. Under the title of Trial of Intensive Blood Pressure Control in Older Patients with Hypertension. The background of this trial is the impressive cardiovascular benefits were observed with the intensive blood pressure control with a systolic below 120 in the SPRINT trial as presented soon in patients 75 years of age. Then another meta-analysis showed that the systolic blood pressure target of less than 130 millimeter mercury was associated with a decreased risk of cardiovascular events and death, especially in high-risk patients. However, recent large-scale observational studies have suggested that a reduction in the systolic blood pressure to less than 130 in older patients should be applied with caution. So there is still a controversy in this point. The aim of the STEP trial was to assess whether intensive treatment with target systolic pressure between 110 and less than 130 would reduce the cardiovascular risk to a greater extent than the standard treatment, which is systolic between 130 and below 150 in Chinese patients with 60 to 80 years of age with hypertension. The STEP trial was a prospective, multi-center, randomized controlled trial performed at 42 clinical centers throughout China, and the planned follow-up period was 4 years. This was the algorithm of the intensive and the standard treatment patients. They started treating patients with olmesartan or amlodipine 5 to 10 milligram, olmesartan 20 milligram once daily. And they randomized the patients into intensive treatment group and the standard treatment group. In the intensive treatment group, if the systolic blood pressure is below 130, so they will continue. If they are not reaching the target, they add other therapy like ARBs, calcium channel blockers, thiazides, and beta blockers. While in the standard treatment group, the systolic target was 130 to below 150. If the patient's systolic blood pressure dropped to less than 125, so a reduction of the dose or the number of antihypertensive drugs were used. If they are keeping the same threshold, so they continue or add something to reach the target 130 to below 150. These are the inclusion and exclusion criteria of the trial: a systolic blood pressure between 140 to 190 in 3 screening visits, or the patient is currently under antihypertensive treatment with an age between 60 and 80 years, and they chosen a special affinity in the Chinese people, which is the Han affinity. And the patients were obliged to sign a written informed consent. The exclusion were patients with a systolic blood pressure above 190 or a diastolic below 60, secondary causes of hypertension, history of stroke, MI, PCI, CABG, heart failure, AF, hypertrophic or dilated cardiomyopathies, or any valvular lesion requiring treatment. Also, they excluded uncontrolled diabetic patients, severe liver or kidney disease dysfunction, and severe somatic diseases like cancer. After randomization, all the patients were scheduled for follow-up visits at 1, 2, and 3 months, then every 3 months for the follow-up period, which is 48 months, 4 years. So the measurement was done by office blood pressure measurement performed by a trained trial staff member. The office blood pressure monitor, which was OMRA, was used at all participating centers during all baseline and follow-up clinic visits. In addition to this, there are smartphone-based data for home blood pressure measurements for the patients, which they send it directly to the data center. And this was the study design. 8,500 patients were randomized into 2 groups. The number that continued the trial was 4,200 in each group. These are the clinical characteristics of the patients, and as we can see that there is a similarity between the intensive and the treatment group regarding the baseline characteristics, regarding the age, the gender, the body mass index, the systolic and the diastolic blood pressure. Also, the renal functions, the lipid profile, and the medical history. Around 18% or 19% were diabetic, 37% were dyslipidemic, and 6% having cardiovascular disease in each group. And regarding the risk, a Framingham risk score above 15% was present in 65% of the patients in each group. These are the results of the office systolic blood pressure measurements. In the intensive group, the mean was 127.5 millimeter mercury, and for the standard treatment group, the mean was 135.3 millimeter mercury. And these are the results. The primary outcome, which was a composite of stroke, acute coronary syndrome, acute decompensated heart failure, coronary revascularization, AF, or cardiovascular death. And as we can appreciate from the figures, that there is a 26% relative risk reduction in events in favor of the intensive group compared to the standard treatment group. And this was statistically significant with this p-value. Regarding the primary and the secondary outcome data, the primary outcome data, as we all know, it was statistically significant. The secondary outcomes was the separated components of the primary outcome. The stroke was reduced by 33%, the acute coronary syndrome 33%, the acute decompensated heart failure was reduced by a huge number, which is above 70%. Coronary revascularization reduced by 31%, but there is no difference in atrial fibrillation. There is a 28% reduction in the deaths from cardiovascular causes, but no difference in the deaths from any cause. The total mortality, all-cause mortality, there is no difference. Regarding the safety of the trial, the hypotension was more prevalent in the intensive treatment group, which was statistically significant, but other adverse events like dizziness, syncope, fracture, reduction in the GFR, and elevation in the serum creatinine, all were not statistically significant, or almost there was no difference between the 2 groups. So the conclusion of the STEP trial was that in older patients with hypertension, intensive treatment with a systolic blood pressure target of 110 to less than 130 millimeter mercury resulted in a lower incidence of cardiovascular events than the standard treatment with a target of 130 to less than 150 millimeter mercury. This was a brief demonstration of the trial. Then I have some points for discussion. This was published in the Hypertension Research 2022, and this was the effect of intensive blood pressure lowering on risk of composite cardiovascular events in older patients. And this included the advanced trial, the sprint, the step trial, and other trials. And you can appreciate the total or the net result of this pooled data is an 18% reduction in the events favoring the intensive blood pressure lowering, and this was statistically significant. We have also to compare between the STEP and the sprint trial, which was elegantly presented by Professor Karim. Because of the outcomes of the STEP and the sprint trials are almost identical, and this facilitates the comparison. However, there are some differences in the STEP and the sprint trial regarding the patient population and the method of measuring the blood pressure. In the STEP trial, the type 2 diabetes represents 19% of the population in the trial, while they were excluded in the sprint trial. The chronic kidney disease patients were very low in the STEP trial, where there is 28% in the sprint trial, and the STEP trial enrolled a single ethnic group in China. Of course, the sprint trials have a higher cardiovascular risk than the STEP trial patients. And also regarding the method of measurement of the blood pressure, they use the standard office blood pressure measurement and not the automated office blood pressure measurement used in the sprint trial. So in editorial or commentary published 2021 about under the title of what we learned from the STEP and we didn't already know from the sprint trial, they concluded that the Chinese hypertensive patients aged 60 to 80 years enrolled in the STEP study with intensive systolic blood pressure treatment reduced the primary composite cardiovascular endpoints and the stroke risk with no effect on the cardiovascular death or renal harm. The two endpoints that was not or there were missing in the sprint trial. So there are major differences with the sprint, are lower baseline cardiovascular risk and chronic kidney disease prevalence in the Chinese STEP population. This is one point. The other point was also published in 2021 under the title of Lower is Better, Sprinting to Stepping Up Hypertension Research. So they stated that based on these examples, the two trials and the observation that hypertension remains the direct cause of half of the world cardiovascular mortality, the obvious perspective must be that the trials of the blood pressure lowering therapy should keep their mainstay position in supporting human longevity in years and the quality of life. Another editorial published 2022 under the title of Step for Breaking Free from Clinical Inertia. They stated in part of it that from a geriatric point of view, it is precisely after the age of late 70 years that the decline in various organs, reserves, and the multimorbidity often occurs. Therefore, it is necessary to consider blood pressure targets classified by age or alternative biological indicators rather than those without age classification. And this is another point. The last point about my discussion is published in the European Heart Journal under the title of Another Step Towards Tighter Control of Blood Pressure in Elderly. And they stated, I asked the question, is the target of 110 millimeter mercury aimed in the STEP study is too ambitious to achieve a potentially unsafe and potentially unsafe in the elderly patients? And they rapidly answered that the safety results based on a comparable incidence of adverse effects in the two groups appear encouraging, with the exception of more frequent hypertension. However, further analysis are required to exclude that too low blood pressure levels may be harmful for frail and coronary patients. Thank you very much.
شكرا يا سامح، محاضرة very illustrative and very important. واحنا عشان نطبق اللي قلناه احنا هنطبق على نفسنا احنا مش هنقول اسئله وهنسمح بسؤال واحد عشان تو كيب ان تايم، ونرجو ان كله يقتدي بسامح ويسيب السبيكر دقيقه او دقيقتين فور ديسكشن علشان نلتزم بالوقت ما يحصلش اللي حصل امبارح. If anyone from the floor, yes, اتفضل. من فضلك عيد في الميكروفون.
What about orthostatic hypotension? Most commonly, we found with elderly patient if we go with intensive set. Do you advise you screening for orthostatic hypotension? Every visit you calculate blood pressure supine, then after standing by 3 minutes. What's your opinion?
Thank you very much for the question. يعني هو في كذا حاجه. اولا يعني لو شفنا المين بتاع البلاد بريشر في الانتنسيف تريتمنت جروب كان 127 ما كانش 110 زي ما هم كانوا طموحين يعني. فبرضه هم ما كانوش بعيد عن السبرنت ترايل زي ما الدكتور كريم قال انه برضه ما كانوش كل الناس واصلين لل 120 او لكده، فبالتالي ما كانتش فيه يعني الاليمنت ده ما كانش يعني موجود قوي. دي اول حاجه. تاني حاجه ان هم برضو كانوا يعني ستارتنج تريتمنت كان مونوثيرابي، وده برضو كان غريب شويه ان هم كانوا بيستخدموا ايذر اولميسرتين اور املوديبين، وبعد كده يضيفوا لو ما كانوش واصلين للتارجت. فبرضو يعني عشان كده الهايبوتنشن صحيح كان statistically significant. they didn't mention في الادفيرس effects على الاورثوستاتيك هايبوتنشن. ستيل اليوروبيان جايد لاينز اخر جايد لاينز في 2018 في الريكومنديشنز للتارجت قالت not less than 120 which يعني برضه هم الترايل اتشيف ذا سيم، يعني هم كانوا 127.
هو سؤال على السريع بس يا دكتور سامح يمكن والدكتور كريم كمان. هو حضرتك في الستيب ترايل اتكلمت على الكواليتي اوف لايف، هل هي كانت مجرد ترم ولا هم فعلا ميجرنج الكواليتي اوف لايف بكوتشنير مثلا زي الكانساس سيتي سكور؟
لا ما كانش في كويستشن.
ما نقدرش نعرف هم فعلا
كانت
اتحسنوا
اوبزرفيشنال يعني
ولا لا.
كانت حاجه اوبزرفيشنال.
وكريم متهيألي برضو ما فيش. اوكي ثانك يو دكتور سامح، شكرا جزيلا.